This is for Jen.
Morning, Denise.
Morning, Dr. Sun.
Mr. Guys, we're just going to talk about you for just a few minutes, so we're all on the same page and take good care of you, okay?
Great, thank you.
All right.
So at 7:15, we can start our briefing. Everybody's here. So my name's Denise. I'm going to be circulating.
My name's Bill, I'm the perfusionist today.
My name's Jennifer, I'm the PA, I'll be first assisting.
I'm Dr. Sunt, we know each other, I'm the surgeon.
I'm Doug Shook, the anesthesiologist.
Hi Kevin, I'm Marissa, I'm the scrub tech.
Okay, so this is Kevin Grace, hospital number 010-3466.
Yes, agreed.
So, and Kevin's allergic to penicillin. He gets a rash.
Yes,
So-
he does.
Okay, so what procedure we're going to do, Dr. Sun?
So we're gonna do a mitral valve repair, cryo maze, and a cabbage ×3.
Okay.
We're gonna use the Lima to the LAD.
And he had a bilateral lower extremity vein stripping in the past.
Yeah, I'm sorry I wasn't booked that way,
Okay.
I didn't appreciate that until Jen picked that up out in the holding area. We'll use the Rima as well as a radial artery for the other grafts.
Okay, so if you want to mark his arm, it might take a few minutes for us to get the supplies up from Central Supply for the radial artery.
All right,
The Allen
I'll
test
tell
was
him to put a
negative
rush on it too.
in pre-op on the left.
okay.
So I'll tell him to put a rush on it too. So would you like the annular shape rings in
Yeah,
order
that'll
for
be-
the repair? if we
That'll
do
be
it?
fine.
Two.
Use the annular shape for the mitral repair. If we're unable to repair the valve, we'll use a mechanical prosthesis.
And that's what you agreed with? You wanted to have done for you, Kevin?
Yes,
Okay.
thank you.
So any other special equipment besides, you want the cryo maze in the room?
Leave the cryo maze.
Okay.
His ejection fraction's a bit low, so I think we ought to have a balloon pump in the room, and we'll put a femoral heart line in on the field once we've got it grafted through.
Yeah, he'll take a 40cc balloon, we have that on the shelf, and I actually have a console in the room already.
Okay, good. So any airway concerns?
Yes, he may be a difficult intubation, so we have a fiber optic scope available just in case.
Okay, any antibiotics since he's allergic to penicillin?
Yes, we're going to give, instead of penicillin, we're going to give vancomycin 1 gram.
And what about Amicar?
So we will use Amicar for the case. In addition, we put a right radial arterial line in anticipation of the left radial heart, as when I spoke to Jen in pre-op.
So as far as perfusion goes, you got his height and weight?
Yeah, so he's 165 centimeters, 65 kilos, which gives him a BSA of about 1.7. Target flow rate will be 4.1, so we're thinking a 21 French arterial and bicable venous cannulation with 224s.
I can put a larger pipe in the IVC for you. We can use a 24 in the SVC and a 28 or a 32 in the IVC, and then you won't have any trouble with your venous return.
Okay, do you want an LV vent?
I think we can just use a drop sucker.
Okay, thank you.
Antegrade, retrograde?
Let's give antegrade cardioplegia, we'll use Delnito.
He doesn't have any cerebral vascular disease, so I was planning to keep his pressure around 60, and we'll be cooling to 34 degrees.
Okay? That should be fine.
His pre-op crit is 36, so post-dilutional?
Yeah, post-dilutional crit will be 22, so I think we should have 2 units ready to go.
I ordered 2.
Okay, great.
Without
I
telling
will,
you, just to have it ready.
okay, thanks. I will wrap him, and I'll have the hemoconcentrator ready as well.
Be
Okay.
nice not to transfuse him if we can help it.
Agreed, let's wait till we get on bypass and see
Yeah.
what the crit is.
But I'll just have it in the room, just so we know. Anybody else got anything they want to bring up or discuss? Okay, that's great.
Okay.
Done.
Thanks, so let me know when you're ready, I'll
Yeah,
be
page
in
news
my
when we
office.
start.
just gonna start
Thanks.
this.
After he's asleep,
Okay.
in our position. You're gonna go sleep, we're gonna take good care of you.
Thank you.
So you saw a different briefing there, and let's compare that briefing with the previous briefing. Now this one is not perfect, but it's certainly some improvements over the last briefing. And you can tell instantly the tone that the surgeon sets when he enters the room and the pace means that he's really giving the respect to the briefing that it deserves, saying this is an important activity that we should all do together. And the language used really creates a culture of communication and sharing that will set the team in good stead. Now this briefing has given team members the opportunity to cross-share information and to check that things are as they should be. And you can see that people are offering or speaking up about things that they're concerned about and things that they think other team members should know about. And this breaks down silos between professional groups, and so there's more chance that this team will work in a collaborative, cohesive way later in the case. And in fact, you can see this if you think about Bill now compared to the last briefing, the bad briefing. In this briefing now, I think we're more confident that Bill can speak up if things are not going well, or if the pace of the operation is not right, or if it's something he's not so sure about, because the briefing has given him the foundation to do that. And the real key here is to do this consistently before every case in this kind of manner. This is not a once a month or once every 6 months task. Doing it consistently will create and reinforce this culture of communication. Just to finish, it's important to point out that this briefing only takes a few minutes at the start of the case, and other industries do this routinely for every case because they know that when people have a shared mental picture about what is going to happen and have shared their concerns, there is more chance that errors will be picked up during the case and more chance of successful performance.